Good morning, everybody from Vancouver. My name is Ed Conway. I'm the director of the Center for Blood Research at the University of British Columbia. It's my pleasure to welcome you to this 14th annual Earl Davie Symposium. I'll start by stating that we believe, whoops, I'm going to go back one. We acknowledge that UBC's Vancouver Point Grey campus is situated on the traditional ancestral unceded territory of the Musqueam people. We also recognize that you are joining us today from many places near and far and acknowledge the traditional owners and caretakers of those lands. We believe that equity, diversity, and inclusion are essential components of all individuals and communities, and we encourage everyone to reflect, to learn, to communicate, and to take action to end all forms of human injustice. To start, I wish to acknowledge our sponsors, Novo Nordisk, the Naiman-Vickars Endowment Fund, Pfizer, Bayer, Canadian Blood Services, BioRender, Alexion, and Grifols. These have been long-time sponsors of the Earl Davie Symposium. We really appreciate their support. And of course, there are many not so behind the scenes people without whom we could not run these symposia, in particular Mira Milutinovich, who's our office manager, Stephanie Mack, who's our education program manager, Ed Prysdale, the associate director of the Center for Blood Research, and Christine Ho, who is our communications coordinator. And I'm just going to call on Christine just to make a few comments. Christine?
Thanks, Ed. Just a note that you can engage with us on social media. We'll be live tweeting throughout the day, so be sure to follow us on Twitter. And if you're going to share your symposium experiences, please tag us and do use the event hashtag. I'll put all of that information in the chat. Back to you, Ed.
Thanks.
Thanks.
This is our first virtual version of this symposium, and our first one since Earl's passing earlier this year. But in his honor and to carry on his remarkable legacy, we've got a fabulous program and a larger audience than we could otherwise accommodate. It's wonderful to see so many new faces and names, as well as many previous Earl Davie Symposium speakers and attendees and old friends. And we hope you will stay all day and participate. We've left time after each presentation for questions and discussion. I encourage you to send in your chat comments and questions, and we can open up the mics if you want to actually speak, which we do encourage. And we encourage particularly trainees to ask questions and get engaged. There will be 3 health breaks throughout the day, and we'll so you can stretch and have your coffee. Very brief introduction to the Center for Blood Research. We are a multidisciplinary, multi-faculty center of more than 35 clinical and basic science investigators from UBC, with approximately 250 research associates and trainees at different levels, as well as technicians. Our major areas of research are in hemostasis, thrombosis, transfusion medicine and inflammation and wound healing, and tissue regeneration. But of course, this extends into many disciplines. A major emphasis of the CBR is to facilitate meaningful interactions between groups and to enhance education and career opportunities. And so this symposium fits well. The CBR was created in 2002, and there you can see the founding director, our own Ross McGillivray. Ross, along with many others, did his postdoc with Earl. It is he who started the symposium, which has since grown. This cascade turned 56 this past September, a discovery that has impacted countless millions of people around the world, not to mention the careers of many in this room and many to come. Earl Davie grew up in near Mount Rainier in Washington State. After completing his Bachelor of Science in Biochemistry at the University of Washington, he joined the lab of Hans Neurath to pursue a PhD in biochemistry. It was Hans who encouraged him to study trypsin and how it changed from a zymogen to a serine protease. And emerging from that work was the concept of limited proteolysis, which is a central theme of the coagulation cascade. After a postdoc in Boston, Earl took a staff position at Case Western Reserve University in Cleveland, where a most famous collaboration with Oscar Ratnoff was initiated, and the notion of a cascade for blood clotting was conceived. After isolating factor 12, then known as Hagman factor, he and his students, then at the University of Washington in Seattle, including our own Ross McGilvery and Hélène Coté and others, proceeded to purify, characterize, and clone a majority of the components of the coagulation and fibrinolytic systems. His lab was not only recognized for its productivity and for churning out fantastic scientists, but also for its wonderful, fun environment. I understand that there were many parties. In 1981, Earl co-founded Zyma Genetics with Michael Smith and Benjamin Hall, which yielded recombinant insulin and factor 7A, both of which are foundations of success for Novo Nordisk, one of our sponsors. Needless to say, Earl received numerous awards that recognized his contributions. Earl sadly died earlier this year, and we will miss his presence, the kindness of his smile, his cheer, and generosity. This and his science will carry his legacy on for generations. It's truly an honor to help in this endeavor by holding this annual symposium in Earl's name. Each year, we start this program by bestowing the Naiman-Vickars Professorship on a leading clinician scientist who emulates the philosophies of these two UBC hematologists. Shelley Naiman and Linda Vickars were a husband-wife team of physicians who changed the face of hematology in Vancouver, BC, and Canada. Shelley grew up in Toronto, completed his medical training in Los Angeles, and joined UBC in 1968, where he immediately became a leading figure in the university's hematology community for more than 30 years. After introducing several advanced concepts to study bleeding and clotting disorders at Vancouver General Hospital, he became the founding head of the Division of Clinical Hematology in the Department of Medicine. He established the first bone marrow transplant center at Vancouver General Hospital in 1981, and later became the head of the hematology laboratory at St. Paul's Hospital, where he created the first clinic for hemophilia. Linda Vickars was born and raised in British Columbia, trained at UBC as an internist and a hematologist. At St. Paul's Hospital, she built on Shelley's foundation a world-class comprehensive program in hemophilia and bleeding disorders, as well as an equally excellent program in hemoglobinopathies. Under her direction, both of these programs became internationally recognized. Both Shelley and Linda were widely recognized as superb clinicians and teachers and were keen advocates of promoting science. They were regular attendees at this symposium and awed by Earl's accomplishments. In their efforts to promote excellence in teaching, education, and research that bridge the gap between the lab and the clinic, they established this professorship in their name. The recipient of this award this year is Dr. Jeffrey Weitz. Jeff is a professor of medicine and biochemistry and biomedical sciences at McMaster University and executive director of the Thrombosis and Atherosclerosis Research Institute, so-called TARI. He holds a Tier 1 Canada Research Chair in Thrombosis and also holds the J.F. Mustard Chair in Cardiovascular Research. Board certified in internal medicine, hematology, and medical oncology, Jeff focuses his clinical practice on patients with thrombotic disorders. His research spans the spectrum from basic studies in the biochemistry of blood coagulation and fibrinolysis to animal models of thrombosis and on to clinical trials of antithrombotic therapy. The breadth of his work is highlighted by his over 600 publications in journals as diverse as the JCI, JBC, Biochemistry, Blood, and the New England Journal of Medicine. The recipient of numerous awards, Jeff is a fellow of the American Heart Association, the Royal Society of Canada, and the Canadian Academy of Health Sciences. Jeff is not only an outstanding clinician scientist, but a superb teacher and a great guy. I know that Shelley and Linda would be honored and thrilled that he is receiving this professorship in their names. So Jeff, I'm gonna put you in charge here, if I don't lose you. You can share your screen. You there?
I'm here, Ed. I'm just trying to find my screen.
Okay. I'm ready for you otherwise.
Otherwise, I might ask you to just flash up.
No problem.
I think these are the ones, but let me share. Let's just make sure.
Yep, you're up.
Everybody see that?
We do. I do. Okay, everybody
Great.
good?
Well, thank you so much, Ed, for that kind introduction. And it's really an honor to be here to honor Earl Davie. Amazing that we're hosting this without his presence, and also to honor two clinician educators who really are founding members of the hematology community in Canada. So I'm going to focus on factor 11 as a target for new anticoagulants. These are my disclosures. And what I'm going to talk about in the next 15 minutes or so are why do we need new targets for anticoagulants? What are the new drugs that target factor 11? And what are the indications for these new agents? And I'll also give an update on where we are with phase 2 studies with the factor 11 inhibitors. So after the 60-some year hiatus for development of new oral anticoagulants, we then had, starting in the around 2008, 2009, we had the introduction of the direct oral anticoagulants. And with studies that involved over 100,000 patients, we know that for stroke prevention, atrial fibrillation, the DOACs are superior for reduction in stroke and systemic embolism, but most importantly, they're safer, with a 50% reduction in intracranial bleeding compared with warfarin. And for treatment of venous thromboembolism, the DOACs are at least as effective as what was then conventional treatment with low molecular weight heparin and transition to warfarin or another vitamin K antagonist. But again, a 40% reduction in major bleeding. So with this safety advantage, with the fact that the DOACs can be given in fixed doses without routine coagulation monitoring, then why do we need new targets for anticoagulants? Well, if we step back for a minute, the ultimate goal of anticoagulant therapy is to attenuate thrombosis without increasing the risk of bleeding. And although there's less intracranial bleeding with the DOACs than there's with vitamin K antagonists, still the annual rates of major bleeding are about 2 to 3% in our elderly atrial fibrillation population. And if we add major and clinically relevant non-major bleeding, we have rates of about 10 or 11%, even with the direct oral anticoagulants. And this is problematic because the fear of bleeding still leads to the systemic underuse of anticoagulants for stroke prevention in eligible atrial fibrillation patients. And also it leads to the inappropriate use of low dose regimens of the direct oral anticoagulants, which leaves our patients less protected than they would be with the appropriate doses. So where do we go for targets for interrupting the coagulation scheme? And the current anticoagulants target factor 10A or thrombin, key components of the common pathway of coagulation. But the new agents are targeting the intrinsic pathway, particularly factor 11 and factor 12. And let me tell you why. The recent focus on the intrinsic pathway came to be because new initiators of the intrinsic pathway have been identified. And of course, as Thomas Rennie showed, among others, that there's attenuated thrombosis in mice deficient in factor 12 or factor 11. And patients with congenital factor 12 deficiency don't bleed, and those with congenital factor 11 deficiency rarely have spontaneous bleeding, although they can bleed with surgery or trauma. So the promise of contact pathway inhibition is that there'd be attenuated thrombosis with little or no disruption of hemostasis. Now, what are these new initiators of the intrinsic pathway? Well, they are naturally occurring polyphosphates, including the neutrophil extracellular traps released from activated platelets, the nucleosomes and RNA released from activated damaged cells, and the inorganic polyphosphates released from the dense granules of activated platelets. And these naturally occurring polyphosphates can activate factor 12 and promote factor 11 activation and contribute to thrombosis. And this is just to show you a neutrophil undergoing the process of netosis and how these nets provide a scaffold for platelet adhesion and aggregation, and also activate the intrinsic pathway of coagulation. Platelet polyphosphate can activate factor 11 in two ways. The polyphosphate can promote the autoactivation of factor 12, and activated factor 12 can then activate factor 11. And these polyphosphates also can promote the back activation of factor 11 by thrombin. So an important concept for today's talk is that factor 11 can be activated from above by factor 12A or from below by thrombin. This study published a few years ago by Thomas Rennie shows that in mice deficient in factor 11 or factor 12, there's reduced clot formation at the sites of vascular injury, both arterial or venous injury, and the clots that form are small and unstable and get washed away. And this, they propose that tissue factor initiates thrombin generation, and that initiates clot formation, but that for the clots to grow and to stabilize, you have to have thrombin-mediated feedback of factor 11 to amplify thrombin generation and to form large and stable clots. This slide, the study that we did some years ago, shows that factor 11 and factor 12 are important for device-associated clotting. In this study, we used a jugular vein catheter model in rabbits and showed that with knockdown of factor 11 or factor 12, catheter patency is prolonged, whereas with knockdown of factor 7, it is not, indicating that the device-associated clotting is triggered through the intrinsic pathway. Now, most of the attention on the contact system is focusing on factor 11. And the reason for this focus on factor 11 rather than factor 12 as targets is really because the epidemiologic data linking factor 11 to thrombosis is stronger than that for factor 12, in that patients with congenital factor 11 deficiency are protected from thrombosis, and those with high factor 11 levels have an increased risk of thrombosis. But perhaps the most important consideration is that if thrombin feeds back and activates factor 11, then that would bypass factor 12 inhibition, unless the only mechanism for factor 12 inhibition is for factor 12 activation is through the intrinsic pathway, such as might occur with devices. Now, we have a number of strategies to target factor 11, antisense oligonucleotides to knock down the hepatic synthesis of factor 11, and aptamers, antibodies, or small molecules to inhibit factor 11. what are some of the potential new indications? And I've listed some here just to bring to your attention that the direct oral anticoagulants are here to stay. They're going to be going generic within the next few years. Their cost for them will come down. There'll be more widespread use. So when thinking about the home for factor 11 inhibitors, it's going to be in places where the DOACs fear to go, such as prevention of clotting in devices, or where there is a very high risk of bleeding, such as prevention of major adverse cardiovascular events in patients with end-stage renal disease on hemodialysis, where these patients are at high risk for adverse cardiac events and for stroke, even if they don't have atrial fibrillation, and yet they're very high risk for bleeding. And perhaps factor 11 would be a safer platform for antiplatelet therapy in patients with acute coronary syndrome, and maybe effective for secondary stroke prevention. And you'll see how these indications or potential indications have crept into the focus for the phase 2 studies. Now, the agent that is most advanced is the Ionis factor 11 antisense oligonucleotide. When given subcutaneously, this reduces factor 11 levels as determined by both measurements of activity and antigen. Note that it takes about 3 or 4 weeks to lower the factor 11 levels into the therapeutic range. So these antisense oligonucleotides do not have a rapid onset of action, but once knocked down, the levels stay down for some time. And we did this study in patients undergoing elective knee replacement surgery, knowing the delayed onset of action. We started treatment with the antisense oligonucleotide 35 days before the surgery. And we did indeed knock down the levels of factor 11, as you can see in the green and the purple lines, compared with the control enoxaparin. The primary efficacy outcome was the incidence of venous thromboembolism. Most of the venous thromboembolism in these patients is asymptomatic deep vein thrombosis detected by mandatory venography that was done in these patients at day 10 plus or minus 2 days. And you can see that the rate of VTE with enoxaparin was 30%, 27% with the low dose of the antisense oligonucleotide, and down to 4% with the high dose. And this marked reduction in the rate of VTE was not associated with an increased rate of clinically relevant bleeding, the composite of major and clinically relevant non-major bleeding. Now, the antisense oligonucleotide has also been evaluated in patients with end-stage renal disease undergoing hemodialysis. And in this first pilot study, a small number of patients were given either the antisense oligonucleotide, the blue and the green lines, or placebo. And you can see, like what we saw with the antisense oligonucleotide in the knee surgery patients, in these patients, the ASO also lowers the levels of factor 11. All of these patients received routine heparin during their dialysis, and we assessed the circuit clotting using this visual scale and considered category 3 or category 4 clotting events on the air trap or the dialyzer as severe clotting events. And you can see that even with heparin on board, air trap and dialyzer clotting events were reduced with the antisense oligonucleotide. The other phase 2 study that has been completed is with sosumab. This is a humanized monoclonal antibody that inhibits factor 11A. And in healthy volunteers, you can see the very nice dose-dependent pharmacokinetic profiles. And with the higher doses, one injection of sosumab gives factor 11A inhibition for about a month. And in the Foxtrot trial, we randomized patients undergoing elective knee surgery to receive either post-operative ososumab in doses ranging from 0.3 milligrams per kilogram to 1.8 milligrams per kilogram, or to preoperative administration of the lowest and the highest dose of ososumab. And the major comparator in the study was enoxaparin, much as we used in the knee study with the antisense oligonucleotide, but we also included apixaban as an exploratory for analysis. The primary efficacy endpoint was again VTE, mostly driven by asymptomatic deep vein thrombosis detected on venography, and the primary safety endpoint, again, the composite of major and clinically relevant non-major bleeding. As you would expect, the ososumab prolonged the APTT and had no effect on the PT, consistent with its capacity to inhibit factor 11A. And if we look first at the primary efficacy outcome, you can see that the rate was VTE was 26% with enoxaparin, and all doses of ososumab except for the 0.3 milligram per kilogram dose given either postoperatively or preoperatively were non-inferior to enoxaparin, and the 1.8 milligram per kilogram dose of ososumab given preoperatively was superior to ososumab, and the rates with that dose were even lower than that with apixaban. Rates of bleeding were low, did appear to be somewhat dose-related with slightly more bleeding events in the preoperative high-dose ososumab group, but still rates were lower than that observed with enoxaparin. So where do we go from here? With that study with ososumab, we identified the 0.6 and the 1.2 milligram per kilogram dose as doses to carry forward, and ososumab is now being evaluated in patients with end-stage renal disease on hemodialysis and is being compared with placebo. A second generation factor 11 antisense oligonucleotide, now one that is ligand conjugated to target it to the liver and to enable administration of lower doses and once monthly administration, also is being tested in this patient population against placebo. And again, the effort here is to look for reduction in major adverse cardiac events. Abelacimab is a factor 11 binding antibody that binds to factor 11, locks it in its zymogen conformation so that it cannot be activated either by factor 12A or by thrombin. And this is being compared with enoxaparin in a study in patients undergoing knee replacement surgery. And we hope to be able to present the results of that study at the ISTH Congress next year. Now, a lot of interest in small molecules, and there are two small molecules that are in phase 2 right now. This one is a joint venture between J&J and BMS. And this small molecule is being evaluated in 2 phase 2 indications for secondary stroke prevention in patients with non-cardioembolic stroke, where different doses of the small molecule are being compared with placebo. All patients get dual antiplatelet therapy with aspirin and clopidogrel for 21 days, followed by aspirin alone thereafter, and treatment is for 3 months. And the major efficacy outcome is a reduction in both overt and covert stroke, and the major safety outcome is, of course, bleeding. There is also a study in patients undergoing knee arthroplasty where this small molecule is being compared with enoxaparin. Bayer also has a small molecule factor 11A inhibitor, and This is being investigated in 3 phase 2 indications, again for secondary stroke prevention, compared with placebo on top of single or dual antiplatelet therapy, against apixaban for stroke prevention in patients with atrial fibrillation, and for secondary prevention in patients with acute MI. The small molecule 11A inhibitor is being compared with placebo on top of mostly dual antiplatelet therapy. So in conclusion, we have factor 11 emerging as a promising target for new anticoagulants. You've seen the multitude of strategies to inhibit factor 11 that are under investigation, and ongoing trials will determine the benefit risk profile of factor 11 inhibitors. Are they really safer than what we have right now? And can they go into indications where other agents have failed? Thank you very much for your attention. I'd be happy to answer questions. I'll turn it back over to you, Ed.
Thanks, Jeff. That's great. Maybe you could just unshare your screen and we can see people. And please, you can ask questions via chat, or you can just unmute yourself and ask questions. So, Jeff, I know that you said that oral anticoagulants are here to stay, or not, the DOACs are here to stay, but we might have said that 15 years ago about Coumadin and heparin, or Coumadin in particular. So there's obviously been a move. Do you think in 10, 15 years that will change?
Well, I think that the DOACs have taken over the oral anticoagulant market from warfarin. If we look at the number of prescriptions written for oral anticoagulants, the prescriptions for warfarin have declined dramatically, and prescriptions for the DOACs have increased. Where each one places in that, changes a little bit from month to month and year to year. So I think that the DOACs are going to be here as options to replace warfarin. But the big question is, can we do better than the DOACs? And going head to head against the DOACs would be a daunting task because the DOACs are so effective, for example, for stroke prevention and atrial fibrillation, and the bleeding rates are still low. You would have to, power a study for superiority on bleeding and at least non-inferiority for efficacy.
And the advantage in stroke, presumably after fibrinolytic agents, do you think that there will be an advantage of 11 inhibitors?
Well, first of all, it's really not after fibrinolytic therapy. Fibrinolytic therapy or thrombectomy is used in only a minority of patients with acute ischemic stroke. And these are patients with non-cardioembolic stroke. So although we are now have extended the criteria to include patients who come from thrombectomy or fibrinolytic therapy, it's really focused on patients who don't get those therapies. And the question is, can you protect the brain from recurrent stroke? We know these patients are at high risk for recurrent strokes, both overt and covert, and can factor 11 inhibition reduce the risk of those events? And that's the strategy that's being tested.
Other questions? We have chat that's open, or you can.
Yep, Prysdale here.
Prysdale, good.
Jeff, I just want to say thanks for a great talk, and comments to all the trainees, students out there that I've been harping on, that slides are simple. Very few words on the slides. Your main points are highlighted, and I would like to use this as the paradigm for talks. So trainees, take note. Question. I'm interested about the relatively long time that it takes to get the 11 levels down to achieve efficacy using the siRNA. And I'm wondering if that's telling us about either the mode of entry of getting the RNA in, or whether that's telling us about 11A or 11 stores that have to be depleted first, or something else about the mechanism? Because certainly, as I recall, the 11 halftime is only about 2 days.
Oh, it's a little longer than that, but it takes some time. It's interesting, Ed, and a great question. And I've asked the experts who in both siRNA and in antisense oligo technology, why is it that the siRNA approach can knock down the levels a little bit faster than the ASO approach? And maybe Christian Kastrup can help us with that, but I haven't received a particularly yielding answer. So but I think that either way, with the focus here is on the antisense oligo approach. It's not going to be an approach that will give us fast onset. So if we're going to use that strategy, we'll have to use it in patients where we're going for a chronic indication and not an acute indication, unless we bridge those patients somehow with other therapies. But the antibodies and the small molecules have a rapid onset of action, and they could be used for acute or chronic indications. The antibodies are being used for acute indications intravenously, but they also work given subcutaneously. And by modifying the dose, you can get pretty rapid onset of action with sub-Q dosing as well. So that's the strategy for rapid onset of action.
Alex, you have a question. Why don't you ask it?
Hi, Dr. Weitz. Really great talk. I remember seeing you present at my platelets course back at McMaster. I had a quick question about, I've heard fibrillar collagens in the vessel wall being proposed as a negatively charged surface capable of triggering contact pathway activation. Do you think this could be involved in why some patients on these factor 11 inhibitors experience mild bleeding symptoms?
Yeah, I don't know, Alex. I think that the collagen does provide a negatively charged surface that can serve to activate factor 12, and until we identify these naturally occurring polyphosphates as physiologic activators, we thought that maybe collagen might trigger factor 12 activation when you get denuding vascular injury. But I'm not sure that it's the explanation for the mild bleeding that occurs even with the factor 11 inhibitors. What we have to find out is really what is the rate of bleeding with the 11 inhibitors compared with the standard of care. And with the trials mostly being done in knee replacement surgery, the surgeons are getting much better, and the rates of bleeding after elective knee replacement, they're really low. So it's a great model for testing efficacy. It's not the best model for assessing the bleeding risk, and we'll have to look for other indications. I see that Christian Kastrup is asking about strategies for reversing the factor 11 antisense oligonucleotide, and he's correct. You could give replacement therapy with either fresh frozen plasma or with factor 11 concentrate. So that would be the strategy for reversal. Much more difficult to reverse some of these long-acting antibodies, and of course the small molecules, they have a short half-life, so the need for a reversal agent is probably going to be lower, but at least for some of them, specific antidotes, much as the way we have the antibody fragment to reverse dabigatran, that strategy could also be used to reverse these factor 11 inhibitors.
Has a plasma transfusion, has that been used?
We haven't had the need to use any reversal. There was one patient in the study who completed the study, still had low factor 11 levels and had a gunshot wound to the popliteal fossa that's behind the knee, and underwent a vascular repair without any complications, without any need for replacement. So far, there hasn't been a need for reversal, but the main strategy for reversal is still the use of tranexamic acid to inhibit fibrinolysis, and then consideration of reversal agents like the FFP or factor 11 concentrate for the ASO, and even low levels of factor 7A could be used for the small molecules or for the antibodies.
Okay, thanks.
Can I ask a question?
Yes, Cedric.
Hi. Is there any way any of this can be converted to oral therapy? Because obviously the attraction of the DOACs is their oral chronic administration.
Yeah, well, Cedric, two of the, both Bayer and this collaboration with BMS and J&J, those are small molecule oral inhibitors with rapid onset of action, like the DOACs. The Tmax is approximately 2 to 3 hours, and the half-lives enable probably once daily dosing or possibly twice daily dosing, but they certainly will be once or twice daily dosing agents. So we have two small molecule oral agents that are in phase 2, the last two that I spoke about.
Thanks.
Any other? Oh, Dave Farrell. Dave? Okay, I'll read this. One strategy that has been used in vitro to reverse antisense oligos is to use the reverse complementary oligo. Jeff?
Yeah, and Dave is right. You can use a reverse complementary oligo. That really hasn't been investigated. It's been investigated experimentally, but not really clinically for reversal of the ASO. But Dave's right. That is another strategy that could be used.
Makes sense. Any other questions? We have silence. Great. Jeff, thank you very much for a fabulous presentation, as always. We really appreciate you. Well, it's not getting up early for you, but for participating in this symposium.
Well, I'm so glad that we got Ross up so early.
Yeah, that's a challenge. Exactly.
That's an accomplishment, and I'm so honored to be named as this visiting professor and to honor Shelley and Linda.
Well, we hope to get you out here in person soon. All right. Take
I'd
care.
love to.
Stick around. All right. Next up, Julie, are you around? Julie Reis. Oh, she is. Good morning or good evening, Julie.
Good evening.
Are you going to, let me, before I introduce you, are you going to share your screen?
Yeah, I'll share my screen.
Okay, good. So you can do that. And I'm going to introduce you.
Okay.
So our next speaker is Dr. Julie Reis, who is an assistant professor at the Institute of Cardiovascular Sciences at the University of Birmingham in the UK. Julie completed her PhD in 2007 at the University of Denis Diderot, Paris in France, working on the role of von Willebrand factor and ADAMTS13 mutations in thrombotic and bleeding disorders. During her postdoc fellowships, she investigated novel mechanisms by which the crosstalk between the hemostatic and complement systems regulates innate and adaptive immunity. In 2014, she joined the Birmingham Platelet Group, focusing on the non-hemostatic functions of platelets, and particularly in inflammation, infection, and tissue repair. Her current research focuses on the functional relevance of platelet innate immune system interactions in sterile inflammation and infectious diseases. For her accomplishments to date and in the future, she was recently awarded a most well-deserved British Heart Foundation Fellowship, and we're pleased that she is staying up late into the evening to speak at this symposium. So Julie, you're on. You can go for it.
Hi everyone, thanks Ed for the invitation. I'm honored to present today. So I had mentioned I'm interested in platelets, but mainly in the non-hemostatic functions of platelets and focusing in both sterile inflammation and infection. And this is what I will be talking about today. Mainly, I'm presenting non-published data that I would like to share with you on the role of platelets and the resolution of inflammation. So as we know, platelets are well known to contribute to thrombosis and hemostasis. And this is classical with platelet rolling on the activated or injured endothelium, and then with formation of platelet plug to arrest the bleeding. And any uncontrolled platelet activation can lead to thrombotic issues. However, won't be the focus of my talk. I will be talking about their other receptors in inflammation and infection. And this is not surprising that platelets have roles in inflammation and infection, because they express multiple receptors that can be expressed at the surface of resting platelets, but also can be upregulated after platelet activation. It's very important to note that many of these receptors are expressed on human and mouse platelets, and some of them are not, like Fc gamma R2A or other receptors. But for my purpose, at the purpose of my talk, I'll be talking mostly about the CLEC2. So CLEC2 is expressed on both human and mouse platelets, and I do believe that the observations that we have can be translatable to human disease. So we know that platelets regulate both the development and the resolution of the inflammation. However, in opposite to what we know about their function in hemostasis, that is much less tissue and organ dependent, their role in inflammation and the resolution of inflammation is receptor and organ dependent. And they have been described to play a role in the acute pro-inflammatory phase, which is an important phase to eliminate pathogens and cell debris. And more recently, we're hearing more about the role of platelets in the resolution of inflammation. However, we know much less about this angle and the phase of platelets in the resolution of inflammation. And this is really important for tissue repair and the restoration of homeostasis, because a non-resolved inflammation can lead to chronic inflammation and then organ damage. And any pathway that we can use platelets to regulate this acute and the resolution of inflammation can be beneficial in many chronic inflammatory diseases. And it's really important to note that, as we can see now in COVID-19 patients, that this chronic inflammatory disease increases susceptibility to also secondary infections. Therefore, trying to understand how we can modulate the inflammatory response can also decrease the potential deleterious effect of a secondary infection. One of the major roles by which platelets regulate inflammation and infection and by interacting with immune cells. A lot of this is a scheme just highlighting some of the functions and interactions of platelets with immune cells. And it has been studied for like many years now. And we know that platelets are really important in recruiting immune cells in the blood. They help recruiting neutrophils, monocytes, they promote adhesion, transmigration, and these interactions also can regulate thrombus formation and stability. And at each of these steps, we do have some interactions that are important at many steps, but some other interactions are specific to specific function. Looking at what happens between platelet and immune cells in the blood has been largely studied. And this is also easy to translate it to patients, because we can look at these interactions with neutrophils and monocytes by taking a tube of blood from patients, and we can correlate it. It's more complicated to understand what platelets function is in tissue, or how they can interact with immune cells in tissues. And this is one of our major focus, is really to understand that we know that platelets can get to the tissue and then can modulate the immune functions of stromal cells, but also immune cells in the tissues. But this is more challenging, just because to access these samples from patients are not easy. So we do use experimental model and then co-culture experiments to address this point. And this is what our main focus in the group is to understand mainly what happens in the tissues, how platelets get to the tissues, and how they interact with immune cells. And we focus on their interaction with macrophages. So the first question we ask, do they interact with macrophages? If we see in healthy tissue, we only know that platelets can interact with, mainly in the liver, with Kupffer cells, in the touch and go interaction that I will explain a bit later. But when we looked at inflammatory models, in many studies we've done, but other people have done a lot of work on this. So this is a model of skin inflammation, the reverse Artus reaction. And at the start of inflammation, so this is a poroplanin positive macrophages, so which is a marker of inflammatory macrophages. And when we looked in the tissue, we could see these macrophages covered by platelets. So platelets leave the blood vessel to and interact with cells in the tissue. This is also true when we look at other models like zymosan-induced cutaneous inflammation. Again, in green are macrophages, and we can see platelets. This is in red, the blood vessel. So they do leave the vasculature to the tissue where they can interact with macrophages. And this is not only in the skin. This is in a model of, this is Klebsiella pneumonia-induced pneumonia. It's surprising to see that most of the macrophages in tissue in inflammatory models are already bound to immune cells. So we can see here in this model that around 60 to 80% of macrophages are already in the alveolar lavage. These are already bound to platelets. So just to talk about more specific interaction that we know that can regulate platelet macrophage interaction, we know that it's really dependent on the tissue, on the timing of the interaction, and of the stimuli. One of the most studied interaction of platelets with macrophages is in the liver, and we know that in the non-inflamed liver, the platelets interact with VWF Kupffer cells in a touch and go interaction through GP1B, and part of the immune surveillance of in the liver. When we look at inflammation or infectious model, this is where we can start seeing differences to the different pathogens that are injected and the timing, if it's a chronic or acute. And then there's two interactions when we talk about platelet macrophages interactions, two receptors that are involved in different, so far in different tissues. We have GP1B that plays a role, and CLEC2 by interacting with poroplanin. And the roles of these two receptors have been described in the liver, but also have been described in the infected peritoneum. And this is using different pathogens. It's important to note that GP1B is consistently expressed like CLEC2 on platelets. However, it's mostly regulated, the interactions are mostly regulated of whatever macrophages can express to regulate these interactions and dictate which receptor will be involved. Just in brief, what is CLEC2? So CLEC2 is one of the 3 ITAM receptors that are expressed on platelets along with GP6 and Fc gamma R2A. Fc gamma R2A is not expressed in mouse platelets, only in human, but there's a model of transgenic knock-in mice that can be used. And they do signal in a similar, very similar pathway through 6-SARC PRC gamma 2 activation and leading to platelet activation and aggregation. Also, a lot of the studies that were done with CLEC2 focused on looking at downstream signaling of CLEC2 and how the interaction of poroplanin affect platelet function and then the signaling downstream. What I'm interested in to look to the other side. So what could CLEC2 do to the cells expressing poroplanin, and mainly looking at macrophages? Just to say, what is poroplanin? So it's the type 1 transmembrane mucin-like glycoprotein. It's heavily expressed outside the vasculature, so it's not expressed in the vasculature. It's constitutively expressed on lymphatic endothelial cells, kidney podocytes, lung epithelial cells. And it's mostly upregulated in cancer macrophages and cancer and inflammation on macrophages. They're mostly described to play a role in migration and EMT. CLEC2 is not the only ligand for poroplanin. So poroplanin can bind to CD44, CCL21, a chemokine that is released from the lymph node, also to the RM protein. And these interactions are described in cancer cells to modulate the migration of cancer cells. If we look at poroplanin in inflammation, we know that in different models, this is looking in the peritoneum, in the inflamed and infected peritoneum. When we inflame when we induce inflammation in the peritoneum through zymosan, bicycle ligation, and puncture inducing LPS, we see that most of the macrophages recruited to the peritoneum, the monocyte-derived macrophages are expressed poroplanin. So this is, we can see here with thymosan that most of the poroplanin are expressed on macrophages, and this is also present in other models. So this poroplanin is not only a marker of inflammatory macrophages, it has a function too, and this is what I will be talking about. So what we've done 2 or 3 years ago is to try to understand what's the role of this interaction of infection. What we could see, if we delete in a cecal ligation and puncture model, which is a polymicrobial peritonitis model, if we delete platelet CLEC2, or if we remove poroplanin from hematopoietic cells that delete poroplanin from macrophages, we significantly alter macrophages, inflammatory macrophages number in the peritoneum. So we could see that this interaction regulate macrophage number, but we don't really know how it's happening. So we looked a little bit to how a macrophage behave on its own or in the presence of platelets. So this is a lattice light sheet microscopy of an inflammatory macrophage, and green is active. An inflammatory macrophage is very still, so they don't really move or migrate much. However, when we look at what they behave when we add a bit of platelets to these macrophages, we can see a significant increase in their mobility. And it's important to know that these are inflammatory macrophages, not repair or non-inflamed macrophages. So the project of Joshua's is now third year PhD is really to try to understand what's going on between platelet and inflammatory macrophages, and how CLEC2 poroplanin interaction can regulate not platelet function, but macrophage function, and how this is relevant in the context of ongoing inflammation, and how it can alter the resolution of inflammation. So first, we wanted to see what happens, how platelets regulate poroplanin expression. So most of the studies were done using inflammatory macrophages, and then we add platelets on these inflammatory macrophages. So we know that LPS upregulates poroplanin and then induce an inflammatory macrophage phenotype. If we add platelets on these macrophages only for 1 hour or 30 minutes, we are able to quickly upregulate poroplanin expression on these macrophages. And if we use platelet deficient in CLEC2, we lose this upregulation. So this is not a transcriptional upregulation of poroplanin. This is a quick release of poroplanin from intracellular stores. But also CLEC2 is able to upregulate the other ligands for poroplanin, like CD44, and same it is in a CLEC2 dependent manner. So we looked also how the macrophages look like in the presence and absence of platelets that have CLEC2 or no CLEC2. So this is poroplanin on an inflammatory macrophages, CD44, they co-localize and they are at the leading edge of migrating macrophage. When we add for 1 hour platelets on these macrophages, we can see how spread these inflammatory macrophages become. And then we can see that platelets are leading these macrophages to spread with an increase in poroplanin expression, CD44 expression. And if we add CLEC2 deficient platelets, we lose the spreading of platelets, but we don't lose the interaction of platelets. So this CLEC2 poroplanin interaction is not a binding receptor, it's an immunomodulatory receptor. So we look at different functions of macrophages and see what are the functions that are altered. If we take inflammatory macrophages and we add platelets and we assess their capacity to phagocytose E. coli beads, platelets delay their capacity to phagocytose. So that's consistent with different ways of producing inflammatory macrophages. And if we add CLEC2 deficient platelets, we lose it. So CLEC2 poroplanin interaction modulates their capacity to rearrange the cytoskeleton to phagocytose bacteria. This is associated with a less inflammatory phenotype because they decrease TNF-alpha secretion. And also the platelets, however, can increase their capacity to migrate, as we can see in a wound scratch assay, where platelets can accelerate macrophage migration in this assay. So our next question was, is it something that platelet activation is dependent on platelet activation and secretion from platelets of immunomodulatory molecules, or is it just an interaction between CLEC2 and poroplanin? And to address these questions, we used a recombinant CLEC2 dimeric, which is an FC CLEC2 that is able to cross-link poroplanin to address what is the function of CLEC2 independently of secretion and platelet activation. And what we could see here that the recombinant CLEC2 mimicked platelets in this setting, looking at poroplanin expression, TNF-alpha secretion, and the migration. So that tells us, in fact, that the interaction of CLEC2 and poroplanin does not require platelet activation or secretion to have this immunomodulatory effect. It's the CLEC2 changing the signaling and the functions of poroplanin, and that alters macrophage function. One of the reasons that we looked at the migration is poroplanin is linked to the RM protein. But that was very contradictory because in many studies, it was suggested but never really proved directly. So we looked at using the single molecule co-localization of the poroplanin with the ERM protein. And to our surprise, what we could see here, then on inflammatory macrophages, poroplanin is highly expressed, but we have very little co-localization with the ERM protein. However, when we add CLEC2, and this is for 1 hour on macrophages, we see a significant increase in poroplanin expression and a significant association with the ERM protein, along with macrophages spreading and then formation of pseudopods. So really what's CLEC2 doing is it's rearranging the interaction of poroplanin with its other ligand, leading to actin cytoskeleton rearrangement, and this promotes migration. So we wanted to see what would happen in the context of ongoing inflammation. So to address this question, we injected LPS in mice for 18 hours. And we know that at this time point, we have a lot of inflammatory macrophages in the peritoneum. And after 18 hours, we injected recombinant CLEC2 for 4 hours. And we tracked macrophages in the peritoneum after these 4 hours. For just to keep this short, so we looked at if this interaction, as we thought, is anti-inflammatory. So we could see that compared to the LPS treated cell mice, if we inject recombinant CLEC2, we have a significant decrease in TNF-alpha, an increase in IL-10, showing a shift in the balance between pro and anti-inflammatory setting. But we saw significantly an alteration in the chemokines that are in the peritoneum, especially CCL5 and CCL2. So we looked at different immune cell subtype and presenting only macrophages because these were the only ones that are changing after CLEC2. So we know that these macrophages express heavily poroplanin. And what we could see that compared to LPS, injection of recombinant CLEC2 significantly reduced the inflammatory macrophage numbers in the peritoneum. These macrophages that are in the peritoneum in LPS mice have expressed poroplanin. This is not changed with the CLEC2 expression. However, we could see that an increase in CLEC2 binding, not platelets, macrophage complexes, but these are the recombinant CLEC2 binding on these macrophages. So clearly, CLEC2 is quickly able to remove the macrophages from the site of inflammation. So we tried to see where are these macrophages going. So we looked at different organs, spleen, lymph nodes. And what we could really see is that the macrophages are leaving to the mesenteric lymph node, to the draining lymph nodes. We didn't see any influx in the spleen or other organs. So there was a directed migration of the macrophages in the lymph nodes. And we can see that this increase in CLEC2 binding is associated with increase in macrophages migrating to the lymph nodes. And this is just to show you how it looks like on FACS by staining. So this is a lymph node, mesenteric lymph node, in red is platelets. And then in blue are macrophages. And we can see this is in LPS. We see some macrophages migrating. And in the presence of CLEC2, we can see a significant influx of macrophages to the lymph nodes. One of the questions was, because when we looked at different co-localization, we saw a strong co-localization with T cells in the lymph nodes. So we thought, are these macrophages able to prime T cells? So we've taken these cells from the lymph nodes, stimulate with low-dose LPS in vitro, and then check for IL-2 as for T cell activation. And we could see that indeed these macrophages were able to stimulate T cells, as we can see with increased IL-2 secretion. Now the question was, why do they go to the lymph nodes? Why we didn't see, why is this directional migration to the lymph nodes? This is, now we know that this is due to CCL21, which is one of the other chemokines that can bind to poroplanin, and then these macrophages can migrate better toward a chemokines gradient of CCL21. So to summarize today, so we think that poroplanin on macrophages is a model, is a two-hit model that is important to promote inflammatory macrophage migration. A macrophage that is not inflammatory or resident macrophage do not express poroplanin. So when we target poroplanin, we are focusing on looking at only the inflammatory macrophages. In the context of inflammation or infection, we know that the cytokines or bacterial dams can upregulate poroplanin and making them inflammatory macrophages. What we do show here that CLEC2 is able to further regulate macrophage expression of poroplanin, but also other ligands that are important for migration, like CD44, the cytoskeleton rearrangement, the binding to the ERM protein, and all this is important to regulate macrophage migration. In the context of ongoing inflammation, we believe that this model of injecting CLEC2 at the site of inflammation can become a model to remove the inflammatory macrophages and limit the accumulation of inflammatory macrophages at the site of inflammation, which can help resolve an acute and a chronic inflammation. And in the context of this acute infection, we can see that cross-linking poroplanin in the peritoneal cavity remove the macrophages from the infected peritoneum to the draining lymph node, where these macrophages are able to prime a T cell response. This work was mostly done by Joshua Bourne, who's a third-year PhD student who did an excellent job on this project in very challenging times, with help with Naiman-Vickars Professorship and Martina Kolikia. So it's my team that I really enjoy working with them, and I thank them a lot for all the heavy work that they do. I would like to thank the Birmingham Platelet Group, who have an important structure for us to support us in this work, and also other collaborators that are helping us. And of course, our funders, mainly Compare, British Heart Foundation, and the Wellcome Trust, for funding this work. Thank you for your attention. I'm happy to take any questions.
Fantastic, Julie. Can you unshare your screen so we can see everybody? There's a lot of platelet people out there, so I encourage you to ask questions.
Maybe I go first.
Oh, good. Well done. Okay.
Julie, that was a great talk, and you made a really convincing case that platelets make the macrophages move around. But maybe I missed it. What happens to the platelets? They must get fully activated when CLEC2 gets stimulated. So what happens to them?
So in fact, CLEC2, the recombinant CLEC2 didn't alter the interaction with platelets. So when we've looked at whatever is bound, that was unchanged. I think because the level of poroplanin on macrophages is so high to be saturated by the level of platelets that are in the peritoneum. So we didn't see any change in the platelets that are already there in the peritoneum. So that was a bit of surprise, but when we check the poroplanin level, we need much, much more platelets, and then we don't find these levels in the peritoneum.
But so in a physiological or pathophysiological context, when the platelets engage the macrophages, they trigger a signal through poroplanin cross-linking. But it goes the other way too. I assume that platelets get activated. So do they go apoptotic, or what happens to the platelets in that scenario?
So when they get activated, these platelets are uptaken by macrophages. They are phagocytosed by macrophages. And this is another angle I didn't talk about today, that there's two things, that the first interaction with platelets, but once they get interacted, they are phagocytosed by macrophages. And that another thing that can alter further macrophage function. The interaction receptor on platelets is one thing, but when they get inside the macrophage, they reprogram also the macrophage in a different way, which I didn't talk about today. So yeah, so they mostly get phagocytose at some point.
Thank you.
Well,
Hey, you,
Julia.
I can see you jumping. Go.
Yes.
Hey, you.
Yes, Julie. That was a very impressive talk. And I have to tell you that as an immunologist and also working for platelet physiology for a long time, I want to figure out platelet interaction with the immune system occurs in the when and a well. Okay, you partially address this question. That is beautiful. I would ask you so that this CLAC2 and the planning, this system, have you observed the antibody titer changes if you inject this to the animals during the immunization? And also whether immunoglobulin isotype switched. For example, there is a beautiful report regarding the immunoglobulin switch from IgM to IgG and other isotype, whether this system occurs in the lymph nodes as well as other immune organ to contribute for that.
So what I presented today is an acute model of 24 hours. So we didn't track, I mean, we need to change model and look at the model that is more chronic to look at the antibody response, which we are aiming to do, but with the COVID situation, it's a bit more difficult now. But here what the aim was to show that the cross-linking poroplanning is able to remove these macrophages from the site of infection or inflammation to draining lymph nodes. With the priming of T cell, this is just a priming. It doesn't tell us about the neither IgG levels or any classes of IgG, but it won't be possible because this is an acute non-recovery model. The LPS, a very high dose of LPS. So we need a recovery model to see this. And I can't answer this question because we haven't done it really.
No, I think probably we need a collaboration to figure that out.
Well, there you go.
Yeah.
Other questions?
Hi, it's Ed Prysdale here. Thank you very much for that really colorful and lovely talk. I'm interested in how viruses may interact with platelets, but not in a manner that the platelet is going to get rid of the virus, but how the virus may take over the platelet and use it to productively infect. Now, I'm aware that CLEC2 and DC sign may sometimes be used in the same sentence, just as I have done. And DC sign can be used as a virus receptor, and so can CLEC2. Now, I'm also aware that DC sign is probably not on every single platelet, and I'm wondering if CLEC2 is on every single platelet. And I'm wondering if in certain situations, whether or not that presence can be capitalized by the virus to funnel the platelet in one direction or another, whether it can take the virus into a virus-preferred pathway or an immune-preferred pathway. Are we starting to think about things in that way in your laboratory?
Yeah, I mean, all our platelets express, mouse and human, they express CLEC2. Just the levels between mouse and human are a bit different. Mouse have more CLEC2 than a human.
I'm sorry, does that require platelet stimulation in any manner? Or does it require, is there any differences in platelet age?
I mean, we recently looked at mice that are really old, 24 months old mice. We see changes because the platelet gets a bit more activated, but we don't see change in CLEC2 level. We see change in GP6 level because it gets shed because of the platelets get a bit activated. But with age, we didn't see. However, I'm
talking about the platelet age, not the mouse age. So you don't really know.
The plate. Sorry, not okay. Not the old. We didn't see. We don't see. I mean, I don't think that the CLEC2 is a receptor that gets shed easily. So we don't find any condition where we really see shedding of CLEC2. So I wouldn't say that there's a changing way with the age of platelets as compared to other receptors that get shed. It's not easy to shed CLEC2. Whether viruses can use it, yes, I think it has to be the virus that can interact with CLEC2, like HIV, for example. Sure. If it's a receptor that can recognize CLEC2 and then activate CLEC2, obviously will have an effect. Still, CLEC2 will have an immunomodulatory effect independently of if the virus recognizes CLEC2 or not. However, we might have double effect, one which is the activation of platelets versus only immunomodulatory effects. So it kind of still changed it to reprogram immune cells, but it doesn't have to be only on platelets, but these platelets can start expressing different receptors that can change interaction with immune cells.
Wonderful, thank you.
Julie, can I ask another cell biology question? So that's obviously after platelet interaction with macrophage. So macrophage, in your video, they show macrophage become crazy and migrate, right? So what's the driving force there? So you think this interaction will deliver signal to activate that the macrophage? So have you also see this some adhesion molecules on the macrophage surface be also altered, or in some other way where the platelet could contribute their own integrants such as alpha-2b, beta-3 integrant, as well as other adhesion molecules on the surface that contribute or help this macrophage migration?
So this is what we try to address by using only the recombinant CLEC2 to see whether it's something that comes from platelets as a mechanism of support, and it's not, because the recombinant CLEC2 is able to do exactly what the platelets are able to do. And then this is what we know is doing is changing the downstream signaling of poroplanin, increasing CD44, which is a migration receptor, and it's a co-receptor for poroplanin, changing their interaction with ERM protein and the cytoskeleton rearrangement, and this is driving the force. However, what is driving them to go in the model of acute inflammation to the lymph nodes is CCL21, which is secreted from the lymph node, but CCL21 is another ligand for poroplanin, and that is increasing the interaction of CCL21 with poroplanin and driving them to go to the lymph nodes.
Thank you.
Hey, Julie, thank you so much. That was fabulous. Thanks for staying up. I hope you stay up later to watch us right through till midnight. All right.
Yeah, sure. Thank you so much.
Okay, thank you. All right. We have 3 trainee speakers to go before the first break. And the first one is Stéphanie Reitsma. And Stephanie, I can drive from here. Just have to share my screen. Tell me if you can see this.
Yes, I can see this.
Okay, but I'll put it up. So Stéphanie Reitsma is in the lab of Dr. Owen McCarty from the Oregon Health and Science University, just sort of down the street from us. So we're really pleased to have you. Stephanie, you're on. I guess I can move to the next slide.
Yeah. Yes.
And she's going to speak about the role of platelets in regulating activated coagulation factor 11 activity.
Thank you for this kind introduction and this opportunity to present my work. So I'm going to talk more about coagulation factor 11 and platelet interactions. And targeting factor 11 seems to be a promising antithrombotic treatment, as we already heard earlier from Dr. Weitz' talk. However, there's still a lot of unknown about how factor 11 is regulated in vivo. So firstly, factor 11 can interact with the platelet surface by the platelet receptor ApoE2 or GP1B. But the mediations of platelet receptors in the activation of factor 11 to activated factor 11A is uncertain. And secondly, factor 11A was found to bind to platelets at an unknown locations. And thirdly, platelets contain a potent factor 11A inhibitor, but the overall regulations of factor 11A by platelets remains unclear. And this brings me to my aim to study the mechanism by which platelets regulate factor 11A procoagulant activity. And in the next slide please. Yes. I am going to study more about platelets regulating factor 11A activity using a chromogenic substrate assay. And here I found by incubating different concentrations of factor 11A, as you can see on the x-axis, in the presence of resting platelets, the factor 11A ability to cleave this chromogenic substrate was enhanced compared to the vehicle condition. And this was the same observation as when we use exhausting platelets, which are washed activated platelets. And next, we also took the supernatant from activated platelets, which we call here secretome. And we saw that this completely abolished factor XIa activity. But interestingly, when we use activated platelets where the platelet secretome is still present, the secretome, the activated platelets reverse the secretome inhibition of factor XIa, which indicates that factor XIa platelet interactions can protect against the platelet secretome inhibition. And in the next slide, I tested the role of platelets on factor XIa activity towards its main physiological substrate, factor IX. And as you can see on the left, we saw an increased factor IX activation in the presence of platelets. And I also tested if this factor IX activation in plasma by using a fibrin generation assay. So this is on the right slide, where I use a well coated with fibrinogen to immobilize platelets. I add exogenous factor XIa, and then I start the fibrin forming reaction by adding recalcified plasma pre-treated with the factor XII blocking compound. And as you see in the graph below, the initiation to start fibrin appears to be faster in the presence of platelets. And to look more into this factor XI platelet interaction on the next slide, I look more into this interaction by performing an immunoprecipitation of factor XI and factor XIa after binding to either resting platelets or thrombin-stimulated platelets. And we found that factor XI was able to interact with the platelet receptor GP1B. So the lysate, we fished out the interaction of factor XI with GP1B, whereas factor XIa did not. But we still detected on the Western blot on the right that we found factor XIa binding to the platelet surface. So to summarize in the next slide, yes, thank you. To summarize this study, we found that factor XIa binding to the platelet membrane increases factor IX activation and fibrin generation, and that this interaction potentially protects factor XIa from inhibition by inhibitors secreted by activated platelets. And this interaction of factor XIa with the platelet membrane appears to be at a different site than factor XI, and we kind of confirmed what was published very early on in literature. And with that, I would like to thanks for your attention, and any questions are welcome.
That's great, Stephanie. I'd like to just start by asking, when you incubate the 11A with secretome, and in the experiment that you actually do in terms of identifying that inhibitor, which I'm curious about, if you incubate it with the secretome and then add the platelets, does that reverse it? So in other words, is there some displacement going on, or is there something in the secretome that degrades the 11A?
So in the literature, so we kind of hypothesized probably protease nexin 2 that platelets store in their granules, but it could also be multiple others. And I also have an experiment which I didn't show, where I have the secretome and then I have just my exhausted platelets, so just platelet membranes. And then I do different dilutions of the platelet secretome and look at factor XIa activity. And we see that there is like a dose, that there is no inhibition by the secretome when the platelet membranes are present.
There's a couple of questions. Jose Lopez, does the secretome include microvesicles?
I think so, because if we stimulated the platelets with thrombin and CRP, so it's a very strong activating of platelets to secrete the granules. And I'm not sure about the biology, but I think the platelets then also kind of can secrete some microvesicles. So, but I'm not sure to say that.
And Dave Farrell, GP1B also binds to thrombin. Do platelet membranes also increase factor XI activation to 11A by thrombin?
That's a good question. We didn't look at it specifically in this study. We just focused on like the activity of factor 11A. But yeah, that's an interesting. And there are studies out there that looked more closely into it, but it remains kind of an elusive field with some papers.
We have last questions. Wally Whitehart asks, do platelet-derived microparticles have the same effect as whole platelets?
So I haven't tested that, but when I looked, for example, in my fibrin generation assay, I also tested if phosphatidylserine would be an effector driving the factor 9 activation. And when you just have plasma there and you block phosphatidylserine, then the whole fibrin generation would be blocked too, indicating that the microparticles in the plasma are very important too for this reaction. But I'm not sure about my platelets activating, secreting those particles.
Okay, we'll take two quick questions, all right? All right, because they're all lined up here, okay? So from Patricia, which types of inhibitors might the platelets be producing to protect 11A? Are you proposing that platelets produce inhibitors to say antithrombotic?
So actively, because factor 11 is a dimer, so what I'm actually thinking is that because it's a dimer, it can interact with the platelet surface, indicating a different conformational change, and maybe that's why the inhibitor cannot interact, but we have to look more closely to that. So I'm not 100% sure.
Okay, not knowing, being 100% sure is good. And Wolfgang, what about polyphosphate? Could that be enriched on the surface of exhausted platelets?
So I watched the platelets excessively, so there might some still be there, but we haven't checked for that specifically.
Great. Okay, we'll wrap it up. Stéphanie, thank you so much. That was fabulous.
Thank you.
Thank you. Okay, our next speaker is Lih Jiin Juang. This is a PhD candidate in the lab of Christian Castro here at the Michael Smith Labs in the Department of Biochemistry and the Center for Blood Research. And Lih, I'm going to put your slides up and wait, you're not shared, so I can't see you. Hang on a second. Too much technology here. Can you see that?
Yep.
Does that work?
Yes.
I'll go, hang on. Okay, I can't go. Okay, you're on, I think. But wait, do you have just the slides or do you have everything else?
I only saw my first slide after the title slide.
You good there? Does that work?
Yes, I think so. Yeah.
Okay, go for it. Sorry.
It's okay. So thank you for the opportunity to present here today. And this figure here shown on this slide, published by Davie and Ratnoff in 1964, nicely depicts one of two pathways by which clotting can occur in vitro. And this begins with the activation of Hagman factor or factor 12. However, back then they weren't sure what the agent responsible for its activation was. And since then, it has been well established that humans and animals deficient in 12 do not bleed more compared to their factor 12 containing counterparts, suggesting that factor 12 does not participate in hemostasis, and as has been mentioned before, has been implicated in thrombosis. And so to date, the physiological role of factor 12 remains unclear. Next slide, please. And so over the years, many materials that activate factor 12 have been identified, and this is just a short list of it on the top here. And one of the activators include clay, a silicate-rich material that is a major component of soil. And as shown in the picture on the top right here, a lot of terrestrial animals live in or on soil, and our ancestors had regular contact with soil as well. This led us to hypothesize that maybe factor 12 only contributes to hemostasis under certain conditions, such as when a natural activator of factor 12 was introduced into the wound from the environment. Furthermore, phylogenetic studies showed that factor 12 appeared in the lineage leading to the terrestrial vertebrates during evolution, but has been lost in animals such as birds or converted to a pseudogene in marine mammals. All of these animals are not in regular contact with soil, which leads to the question, are soils part of their coagulation system? Next slide, please. So first, I examined the effect of soil in wounds in a mouse tail bleeding model, shown on the top left here. And blood loss after tail transection was similar in both wild type and factor 12 knockout mice, when nothing was applied to the wounds, agreeing with previous studies. However, things are quite different when there is soil in the wounds, with soil stopping bleeding really fast in wild type but not factor 12 knockout mice. This finding was then confirmed using an in vitro coagulation assay shown on the top right there, where soil triggered faster clotting in normal human plasma, shown by the orange bars, but not in human plasma immunodepleted in factor 12, shown by the blue bars. And in a separate assay on the bottom here, I demonstrated that the procoagulant effect of soil was observed only in human plasma, but not plasma from animals lacking factor 12, including Helen Chester, shown on the picture on the bottom right there, who are two species of dolphins whose blood plasma was used here. Next, please. So now that I have confirmed that the hemostatic effect of soil is dependent on factor 12, I next wanted to tease out what it is about these soils that contribute to its procoagulant effect. So on the top left there, I separated soil into a high clay or low clay fraction and measured its ability to activate 12 using a chromogenic substrate that could be cleaved by factor 12A. And I found that the high clay component of soil, shown by the green bars there, had the greatest ability to activate factor 12. However, this does not exclude the roles of microbes or organic matter in the procoagulant response. So I next treated the soil by autoclaving it or to kill microbes, or treating it with a pyrophosphate solution to deplete most of the organic matter. And as shown in the bottom left figure, either treatment did not affect the clot times of plasma compared to untreated soil. I also flame heated the soil for 1 hour to severely deplete its endotoxin levels, as shown on the top right. And this also did not decrease the clot times of plasma compared to untreated soils, shown on the bottom right here. Next, please. And finally, soil surfaces were analyzed and correlated to clot times. And interestingly, although most materials that activate factor 12, as published in the literature, have a net negative charge, there is only a moderate correlation here between different soils and the magnitude of charge on the different soils and the clot times here. Instead, there was a strong correlation between the surface concentration of silicon and clot times, with soils having a higher concentration of silicon leading to a faster clotting time. So in summary, these studies suggest that factor 12 does indeed have a role in hemostasis when wounds are contaminated with soil silicates. And this may have had an adaptive value during evolution, and explain why factor 12 could have persisted across the evolution of terrestrial mammals, despite seemingly no role in hemostasis in clean wounds. And thank you for listening, and I'll be happy to take any questions.
We have questions. We have questions.
So I have a question.
Okay.
I love this study. We just had it in Journal Club, so congratulations, really beautiful. The one thing I semi-disagreed with is that birds are not in contact with soil. So why would birds kick it out? They still breed in nests and they're still on the ground, and why would that make sense for them?
Right. So I guess birds spend part of their time like flying around, and so they are not as on the soil as much as the mammals that live just on it. So maybe it's possible that have a distinction between the two types of species. And yeah.
So we're gonna lose it in the future if we're not going outside anymore. We're just sitting in our clean houses.
Could be if this hypothesis is correct.
Thank you.
Thank you.
Jeremy Wood has a question. Have you looked at whether soils affect other aspects of the coagulation systems? For example, other negatively charged particles will promote factor 11 activation or inhibitor, TFPI?
Sorry.
Can you read that? So have you looked at whether soils affect other aspects of the coagulation system?
Yes. So I've measured the activation of prekallikrein as well, and other aspects, which I did not have time to go through during this presentation, but is presented in my paper, published in Blood Advances. But to summarize, negatively charged surfaces could also activate prekallikrein, but I've shown that the soil does not activate prekallikrein directly, but instead is mediated through a sort of like a first going through the activation of factor 12 before activating prekallikrein, and also confirmed that the hemostatic effect of soils via the 12 activation of factor 11.
Jill Johnson asked, do I understand that heat was used to inactivate endotoxin? I thought that they were relatively heat stable.
Yes. I put a Bunsen burner flame under the soil for an hour, which for some of the soil with a lot of organic matter, as I can see from the color of the soil being really dark, for some of them, I saw like a bunch of steam and some burning off of things during the reaction. And as measured by the endotoxin assay, this endotoxin level was severely depleted after this flame heated treatment.
Great. Okay. And Paul Kim shared a YouTube that shows bird and soil. I don't know what that's all about because I can't open that right now. But if you're interested, the site is on chat. All right, Lih Jiin, thank you very much. That was fabulous. And we're going to move on to our next speaker.
Thank you.
The next speaker is Lena Witzdam, a PhD student in the lab of Cesar Rodriguez Emeneger. Is that right?
Yes.
Yeah, thanks. In Aachen. And I'm going to share the screen so you can do it. I'll try to do this properly this time. Bear with me. Just have some technical challenges here. Okay, are you on?
Yes.
Can you see the whole screen, Lena? Yeah?
Yes.
Good. Okay, you go. You're good to go.
Okay, my goal is to design the next generation of hemocompatible coatings that are capable of reprogramming blood to fight against uncontrolled clotting. This is the biggest unresolved challenge for all blood-contacting medical devices. And blood begins to clot as soon as it contacts the surface of artificial lung assist, oxygenators, dialysis membranes, and many more. This can cause deadly complications such as stroke or embolism. In nature, clotting is counterbalanced by the fibrinolytic system. In the fibrinolytic system, the endothelium releases a protein that is called tissue plasminogen activator. You can see it here in gray. This protein binds to the fibrin clot and fish simultaneously a protein that is circulating in blood and called plasminogen, the pink ball you can see here. TPA cleaves plasminogen into plasmin, the enzyme that digests the clot. And plasmin is digesting, while plasmin is digesting the fibrin network, TPA is continuously generating more plasmin. After successful digestion of the fibrin clot, the surface is regenerated and TPA and plasmin are deactivated by the inhibitors. So now my idea is to transplant the key concepts of the fibrinolytic system to develop my coating. And on the next slide, you can see how effective my coating is. Okay. Here you can see a microscopic clot being digested by my coating. Like an orchestra director, the coating decides when it's time to activate blood enzymes, to digest the clot, and to stop when the task is finished. And as you can see here, my coating was able to digest the clot after already 3 hours. Let me show you on the next slide how I achieved this. My system has 2 parts.
The first are polymer brushes, here in blue, which prevent the absorption and activation of coagulation factors and platelets, turning the surface sterile. The second is TPA linked to the brushes. However, my coating is doing nothing unless there's a thrombus. And if there's a thrombus, it will activate the fibrinolytic system. So the presence of the fibrin clot switches TPA on and increases its affinity for plasminogen. TPA then captures and activates continuously plasminogen into plasmin, the enzyme that digests the clot. And after the digestion, TPA went back to the dormant state, while plasmin is released to blood and deactivated by its inhibitor. So the fibrinolysis will only occur on the surface and only if it's necessary. It will not affect the hemostasis in the circulatory system. On the next slide, I will show you a kinetic study using a chromogenic substrate that acts as a plasminogen mimic to confirm that TPA is more active in the presence of fibrin. After cleavage by TPA, the chromogenic substrate releases a yellow dye, which could be measured by UV-Vis spectroscopy. The graph shows the conversion of the plasminogen mimic by the coating in the presence and the absence of fibrin. And as you can see, the conversion was much faster in the presence of fibrin, showing that TPA is activated. This is perfect, but how is the situation in real human blood? I will show you this on the next slide. I performed static blood experiment where I used glass as a positive control, bare membranes made from polymethylpentane, the same material that is used in oxygenators, and membranes from the same material modified with polymer brushes and polymer brushes with TPA. I put them in contact with blood for 1 and for 2 hours, and I observed that after 1 hour, blood rapidly clots on the glass surface. On the bare membranes, I could also observe clotting, less on the polymer brushes and very little, if any, on the brushes with TPA. After 2 hours, the difference became bigger, and now much more clotting occurs on the bare membrane. Even with the brushes, there is some clotting, but much less if TPA is present. And you can see TPA is digesting the clot that is starting to form, showing that this system actually is quite promising to deal with real blood. So in conclusion, I'm sure that this system will have a great impact in the medical field, especially for oxygenator membranes. Thank you very much for your attention, and I'm happy to take your questions.
Okay, do we have questions? So Lena, does this have, are there, I'm going to unshare somewhere in a second. I am unshared. Does this have any effects on have you looked at leukocyte, effects on leukocytes in this system?
This we don't study right now. So we're still evaluating and studying this system and the influence in the blood. And so far, we only see that we have a great improvement in prevent clotting. But in for all these other components of blood, we need to study in more detail.
Okay, there's a couple of questions. Have you looked at UPA? It might be more stable than TPA.
No, at the moment, not. Could be also interesting.
And does the system remove a von Willebrand factor VWF coding?
This is also something which is together with the components of blood. We didn't do it right now.
And Peter Grin asks, how are you binding TPA to the polymer coating? Which domain of TPA are you coupling to the polymer? And what kind of chemistry is being used?
We use the amine group of TPA, and we use EDC and NHS chemistry. And our polymer brushes have a carboxylic group. And then we had this EDC NHS coupling between the amine group of TPA and the carboxyl group of the polymer brush.
Great. Are there any other questions? No, it sounds promising. Great. Lena, thank you so much. I want to thank all the trainees and our speakers before that, Julie and Jeff, for a fantastic start to our day. Before we take a short first break, I'm going to show a few slides, but introduce first Geraldine, who from the Canadian Blood Services and the Center for Innovation. So, okay, so I'm being challenged today for some reason about sharing and stuff. So bear with me. You have no choice, actually. Have to bear with me. Are we sharing? We're sharing, and there's your first slide. All right, you there, Geraldine?
I am here, Ed. Yes, I am.
Good morning.
Good morning, and thank you for giving me the opportunity. So my name is Geraldine. I'm from the Centre for Innovation at Canadian Blood Services, and I wanted to take just a moment to announce a couple of opportunities that we have on right now for research trainees who are at the Centre for Blood Research or the School of Biomedical Engineering at UBC, or who are members of the Canadian Blood Services Research Trainee Network, which is a fairly broad network that includes anybody who is funded by Canadian Blood Services or working in any labs or working through any programs that are supported by Canadian Blood Services. So the first of these, as you can see on the screen, is the Lay Science Writing Competition, which is open for submissions until December 15th, 2020. The theme this year is Challenges 2020, which we will leave open to people's interpretation, but we can all acknowledge it's been a challenging year in many ways. So I think this is a great opportunity for any trainees to take this opportunity, tell us about your challenges in your science or research or facing science in general over the last year, and enter to win a cash prize in our Lay Science Writing Competition. So as I mentioned, it's open to trainees, and that includes anything from undergrads, postdocs, grad students, research associates, and transfusion medicine fellows. So do check out this site here, blood.ca/research/funding opportunities, to learn more about the competition and the eligibility criteria. And the second opportunity is a workshop that we're running on November 30th. It's been done by SciCats, who are a collective of Vancouver science communicators. They're going to facilitate this workshop that is again open to all CBS and CBR and School of Biomedical Engineering trainees. It's going to be an excellent opportunity, whether you're entering the Lay Science Writing Competition or not. I encourage you to sign up. The registration link is there, and it's going to help you write and edit your way to clear, persuasive scientific writing pieces. And that's it for me, Ed.
Thanks, Geraldine. That's fabulous. We have a long-term relationship with the Canadian Blood Services. They have been partners since the creation of the Centre for Blood Research. Okay, now I'd just like to call again to Christine Ho. She's just going to make a couple of comments about our fantastic KT team. Christine?
Thanks, Ed. So I just wanted to take the opportunity to highlight the CBR's November magazine, which we actually just published yesterday. So for those who don't know, most of our magazine articles are written and edited by the CBR's Knowledge Translation Team, a dedicated group of scientists who are passionate about science communication and science writing. And our November issue has a lot of fantastic articles on everything from recent research publications to CBR's COVID-19 research, to events, to opinion pieces on important scientific issues. So I'll put the link to the magazine in the chat, and I encourage everyone to take a look at it during the break or throughout the day when they have time, and just see the amazing work that this group has done.
Great, thanks, Christine. Just of note, I think most of you received it in with the Zoom information, and there's on page 34, there's a tribute to Earl written by various peoples. I'm not exactly sure who wrote that. All right, now just a couple of comments. There will be a poster session with breakout rooms this afternoon, so watch for it. And here are the posters, but there'll be more information on that at the next break. So let's all take 10 minutes. We'll aim for 10 minutes. We'll aim to start at 10 o'clock. That's 10 o'clock Pacific time, and other times wherever you are. So we'll see you in a few minutes after you stretch.